again, looking through the evolution of antiretrovirals, we started out with a single drug in 1987, AZT, and then we sort of followed that with dual therapy. And then 1996, we got to an era where we said, all right, this is where you need to use 3 drugs. And that sort of set the stage moving forward for success. With that success then came refining all the things we knew, making the drugs better, and then trying to make them simpler, getting them into single tablet regimens. So where we're going now in the field is, and we've seen a little bit this year for the first time, we had the first in a new treatment paradigm. And from 1996, the standard of care has been using 3 drugs to treat HIV. For the first time this year, we have the approval of our first 2-drug regimen. So eliminating one of the components. And in this case of what was approved now, it was the NRTI, so the nucleoside reverse transcriptase inhibitors. Why those? Well, we know those are the ones associated with a lot of toxicity. So we talked about Truvada. Truvada long-term can cause kidney damage, bone damage, so really eliminating those. And so that's one sort of really a paradigm shift for us because every one of us is used to 3 drugs. Concerns around using 2 drugs are patients who are poorly adherent to drugs. Do they have background resistance? And will two drugs be enough? I think when you look back, when you go back to 1991 when DDI was approved, those 2 drugs were very different than what we're looking at now. Those drugs were not the best drugs, whereas the true drugs now we have in our single pill really are good drugs. So again, one combination approved, another one to follow. And then really right behind that is, again, a whole new treatment paradigm for us, and that's using injectables in depot forms. So where patients will come in once a month, get a depot shot. Again, it's going to be of 2 drugs. We're hoping to be approved cabotegravir, which is an integrase inhibitor, and rilpivirine, a non-nucleoside reverse transcriptase inhibitor, where they would get injections once a month in a depot form, and they would not have to take pills. And the studies that are out there really look well in terms of success rate. So we're really looking forward to those times, and patients are really looking forward. There are many patients who cannot tolerate pills. Many patients don't want to take a pill once a day. For some patients, it's a reminder of their HIV status. So to be able to come in and get a single injection once a month will really be exciting. The guidelines I anticipate, and actually with the latest iteration, one of the new single drug combos, so that would be dolutegravir with lamivudine, was already added as an agent on there, and it's not even approved yet. So I think knowing that these drugs are really efficacious, they're very well tolerated, the guidelines I feel will have no problem putting them up there as really first-line agents. I don't know that they're going to be first-line for everyone. You know, the guideline sort of breaks it up as what drugs are best for everyone and then what drugs are best for certain key populations. And we do know that when we're using 2 drug combinations, it's not for everyone. It's not for someone where you're worried about adherence. It's not for someone where you're worried about resistance. So I think they will put that there, but I do think they will move them up pretty rapidly.